Good morning, good afternoon, good evening to everyone. I'm Monica Sepia, Associate Country Director, India at the Lakshmi, Mittal and Family South Asia Institute, Harvard University. It gives me a great pleasure to welcome all our audience members and panelists on behalf of the Mittal South Asia Institute at Harvard and our co-organizers, Harvard T.H. Chan School of Public Health, India Research Center, and Boston University Foundation, India. The webinar, Approaches, Application, and the Road Ahead for Narrative Medicine in South Asia today, will be hosted for 90 minutes. Professor K. Vishwanath, moderator for the evening, whom I'm going to introduce very shortly, will open the session. After a brief introduction to the field of narrative medicine, we'll have the panel discussion moderated by Professor Vishwanath that will include audience Q&A before we close the session at 7:30 p.m. India Standard Time, 10 a.m. Eastern Time, and 8 a.m. Pacific Time. We request all audience members to use the Q&A box feature in Zoom to post their questions. While doing the activity, if you would like to read out your response, please let us know through the Q&A box and we will unmute you. Please follow the chat window on Zoom to see the notes and messages being sent out by our team. And not taking up more time, I'll introduce all of you K. Vishwanath, Lee Kwam Kee Professor of Health Communication in the Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health and in the McGraw-Patterson Center for Population Sciences at the Dana-Farber Cancer Institute. Professor Vish wears various hats. He's the Faculty Director of Health Communication Core of the Dana-Farber Harvard Cancer Center, Director of the Center for Translational Communication Science, Director, Harvard Chan India Research Center, and Director, Center for Health and Happiness, all at Harvard T.H. Chan School of Public Health. He's also the founding director of Dana-Farber Harvard Cancer Center's Enhancing Communications for Health Outcomes, the ECO Lab. His work draws from literature in communication science, social epidemiology, dissemination and implementation, and social and health behavioral sciences, focusing on equity in health communication and involving community-based participatory research to influence public health policy. Vish has authored over 300 publications on topics like communication inequalities and health disparities. He has served on national committees and received numerous awards for his contributions to public health communication and policy. Thank you very much, Professor Vish, for agreeing to moderate this session, and I hand it over to you to take things forward from here.
Great. Thank you, Monica. Thank you for that very generous introduction. I'm choking up, obviously, here, so I do need a drink of water. But let me first, I think you mentioned that I had something, the Lee Kwam Kee Center for Health and Happiness. I think a part of that is to express gratitude. My philosophy is to express it often and early. So let me first thank you, Monica, and the teams at the Mittal Institute and the Harvard Chan School of Public Health India Research Center for your extraordinary leadership and the work behind the scenes. This is not easy to do, doing it across 2 different continents and across time zones. We really appreciate all the work you have put in. So thank you. I also want to start by thanking our wonderful panelists. You will hear from them shortly, and I'll introduce them in a second here. I just want to say a couple of words about today's session. At a time when we are talking about precision medicine, precision public health, and are getting excited about the tremendous advances in life sciences revolution, in combination with the communications revolution and our revolution in communications and information technology, we are going to talk about something that is centuries old. We are going to talk about something that's very deep and deeply ingrained in human history and human culture today. Just to show that nothing goes out of fashion. In fact, what we are going to discuss today is not just about the science of medicine, but also science and art of medicine and how that can advance well-being on many fronts. I think so. That's why I'm so excited about the topic, and even more excited with the 3 proponents and practitioners who have ably advance that idea and put it into practice in a way that we all can benefit. So this whole idea of narrative medicine, and we will shortly understand what we mean by narrative medicine, how do we define it, and how it is practiced in exemplar institutions in a very short time. And I'll come back and introduce the panelists when we begin that conversation. But so the idea, as Monica rightly said, is that I will first introduce Dr. Deepu Gowda, who will actually walk us through an exercise. This will be very exciting, I think, for people. And then followed by, I'll come back and introduce the other panelists, and then we will start the conversation with them. They will have they will take some time to present their ideas and where they are coming from, how they are practicing. And at the end of their presentations, we'll come back and have a conversation. So I'm sure you will have a lot of questions. And so please go ahead and put those questions, as Monica said, in the Q&A box, so that some of us are tracking them. We will take as much time as is possible to have that to incorporate those questions in our conversation. So that's the rough idea of the program. We'll play it informally. It's all about having fun while learning from these three distinguished panelists. So before I call on Dr. Deepu Gowda, let me introduce him. And then, of course, I will introduce other panelists when I come back. Dr. Gowda is Assistant Dean for Medical Education at Kaiser Permanente, Bernard J. Tyson School of Medicine. He's a general internist. His research includes narrative medicine, visual art in medical education, and interprofessional education. Prior to his arrival at the Tyson School of Medicine, he served at Columbia University, directing clinical practice in narrative medicine and clinical medicine tutorials as chair of Columbia's fundamentals curriculum. And this is important. I'm sure some of you realize why that is so critical, that role as chairing the fundamentals curriculum in enhanced equity, inclusion, and diversity. A former Macy faculty scholar and New York City Board of Health member, he currently co-chairs the NBME Step 2 Clinical Skills Committee, aiming to create a more person-centered, let me emphasize that, equitable healthcare system. Deepu, it's such a delight to have you here. So walk us through this exercise, and welcome.
Thank you so much, Professor Vish, for really that beautiful. First of all, I want to thank you for the introduction of myself, but also the introduction of the field of narrative medicine. This session today is a chance to introduce you to this field and to also think about how this field has impacted different curricula at 3 different medical schools. And for many of you, this is a new term, it's a new concept. So the way that we're going to introduce it to you is to actually have you experience a little bit of it together. This is a field that is in the medical humanities. It's a field that has deeply impacted my understanding and approach to being a physician. I'm a primary care physician working with adults. It's also deeply impacted the way I think about medical education. How should we train physicians and nurses and other people in the health sciences in a way that is person-centered, that is connected to their stories, that's connected to their humanity, as well as training those people to be great technicians and harnessing the knowledge and skills necessary to deliver good care. We believe this methodology of narrative medicine is one of the methodologies that we can use to bring those 2 very important concepts together: technical expertise and bringing in humanity and person-centered care together and serving the people that we're entrusted to care for. So what I'm going to ask you to do now is experience this together. In our field of narrative medicine, we first engage with creative works. It can be poetry, it can be visual art, it can be film, it can be songs. The world is filled with creative works from the dawn of time, of humanity. And that's because creative works help us understand the world. They help us grapple with the complexities and nuances of the world. They're not simply ornamentation. So we're harnessing the power of that. We also do some writing together. So I'm going to ask you to look at a painting in 1 minute. As a ground rule, I want you, the way that we approach this in our audiences, we don't expect anyone to be an expert. Everyone comes to any work of art, any creative work as a human being. And we're just interested in what happens to you in the moment of engaging with the creative work. What are you noticing? So no expertise is necessary. Your direct experience is encouraged, and we encourage your participation. So what I'm going to do is show you this work of art, have you look in silence for 30 seconds, and then I'm going to ask you to place your comments in the Q&A. What are you noticing? It can be a word, it can be a phrase. I'm going to ask you to put that in the Q&A, and then I will I'll invite members that placed comments in the Q&A. I'll select a few to unmute and speak. Okay, and then we'll speak together and we'll build our understanding of the work of art together. So that's how we're going to approach this next section. So let me advance the slide and just encourage you to take 30 seconds to slow down your observation. Even slow down your breathing. And just notice the painting. At this point, I would like to invite you to type into the Q&A anything that you notice. What are you observing? Go ahead and type in, and I encourage all of you to participate if you can. This is a space where there's no right answers. It's really a space where we construct meaning together. Thank you so much for offering these observations. Concerned, dichotomy between light and dark. Child is very sick and examined by the doctor while the father looks on. Concern, worry, grief. I wonder if Dr. Mirabelli, would you be open to unmuting and just sharing with us what you're noticing there? Where do you see concerned? Can you talk more about that word and how that's inhabiting this painting?
Hello, can you hear me?
We sure can. Thank you.
Great. It just the interpretation is coming from the three different. I see three people. There seems to be a child, one child, and you hear my voice. It's just it's just looking at this makes me uncomfortable because they don't seem to be having an answer to a possible issue with the child. That's what I see there.
Thank you so much. So you see at least three people there in the image, and some of you might see more than three people. And you see someone who might not have an answer. Very interesting. What do you see there that makes you say that? that there might not be an answer? Is there something that's being conveyed in body language or objects, images that says we're seeking answers and might not have it?
Well, the person sitting down, the adult sitting down, seemed to be very pensive, and his elbow is leaning against his leg in a way that he's kind of searching, thinking
Mhm.
for an opportunity to come up with an idea that makes sense in the situation.
Thank you so much. You see how much is conveyed through the body. No one is speaking to us. If you listen carefully, you don't hear a thing. But if you use your imagination, the silence in this image is communicating something to us. The body language. And I love the fact that you said the person in the front. And what I like about that is that there's a humility in the words that you used. We don't know who this person is. We don't know what their role is. We can generate hypotheses. We can use our imagination to think of what could be happening. But the humanities and arts allows us to delve into this realm of ambiguity and start to make sense and realize we bring ourselves to this and we start to make interpretations. But you've also taken us to the place of pure observation. The person in the front with the hand like this, could this mean that there's seeking of questions and might not have the answers yet? I'm going to ask Uma to speak. I know you raised your hand as well and put a question in earlier. Terminally ill child deserves better care environment. Can you say more about where you see the terminally ill child? And then next, about the care environment. Could you talk about both of those? Uma
Sure.
M.
Yeah, sure. Am I audible?
You sure are. Thank you.
Thank you. Yeah. I see the child being administered in a very poor medical settings. It is a home
Yes.
which
Yes.
is not very shabby, and there
Mm,
is no air, no light, no proper
mm,
ventilation, and the furniture on which the child is placed is not at all conducive, and
mm,
the jug or the water or whatever the immediate needs of the child, this environment doesn't support. And
mm,
I see the person who is placing his fist over the chin is helpless, and
mm.
that conveys a kind of uncertainty, and
Yeah.
his concern and worry that he is not in a position to provide the adequate care to the child to relieve the child of its suffering. And
Mm.
overall, the environment is not at all conducive, and it's painful to watch, and it triggers some kind of a compassion. That is what
Yes.
I see and observe.
Uma, thank you so much for that very rich description. Um, what you just did is you looked at the painting and you recognized the setting and you said, where is this child being cared for? And you said home. And absolutely, you look at the environment this is in, the child's home, the family's home. The other thing we learned from Uma is that when she's looking at the scene of care, she's moved emotionally, that she feels a desire to want to care for this child. And she's also naturally thinking about how can we give this child the best care that this child deserves. And she's saying, there are elements of this that could be better. And we learned something about Uma in this moment. We learned that when if Uma is a clinician, I'm assuming that you are based on the comments that you made or involved in the clinical environment, that I would imagine you're doing the same thing when you walk into a clinic room or a hospital. You're saying, how can I make things better for the person I'm entrusted to care for in this moment? And that's such a beautiful way to approach your work by bringing your emotions and also bringing in that desire to want to make things better for others. I'm going to quickly read some of the other comments here. Concerned, dichotomy, light and dark. Child is very sick and being examined by the doctor while the father looks on, concern and worry. Grief, observation, concern. Terminally ill child deserves a better environment. Unwell patient. Doctor is observing. Stark-like, ghost-like. Deep sleep. The doctor is reflecting on the child's condition. The jug filled with hot water as I see the steam rising. Beautiful observation. And I want to say hello to Dr. Burnashri. I had a chance to be in Bangalore and speak to her and her team just a few months ago at an international conference for medical humanities. And thank you, Dr. Dasgupta, for your comments as well. Very rich description. And Dr. Dasgupta also says the conditions are not hygienic. Maybe this is a single parent family. The father is a sole caregiver. Some of you might also be able to observe that the figure in the back in the shadow is placing their hand on someone who has the head down on a table with hands resting like this, almost in prayer position. So there's a person back there too, which we interpret as possibly the mother. This is a scene of care. This is a painting by Luke Fields called The Doctor, painted in 1890. You all did a magnificent job of close observation and unpacking where your observations and interpretations are coming from. You pointed to those specific items. This painting was commissioned basically to say, what is a socially important condition? So that was the commission of this painting, to basically say, paint something of social importance. And Luke Fields decided to paint a doctor. That's what this is about. And they decided to paint about a doctor because Luke Fields himself was affected by the tragedy of his own child. The painter's own child developed an illness that was rapidly progressive that resulted in the unfortunate death of his child. Even though the child did not survive, Fields was so moved by the physician's presence at the bedside, but by the physician's commitment and standing vigil in the home of the patient, and the effort that was given, that he was so moved to paint this. And even to this day, this is one of the, in the Western, artistic canon, one of the iconic images that speaks to one of the core values of caring for another, which is presence and attention, as being the core elements of caring for someone else. And we use this with medical students and trainees to convey those notions, but also to enter this field and to be in a place of curiosity and observation. So I want to thank you all for this beautiful interpretation and discussion. So the question is, what did we just do? We just engaged with some of the core methodologies of narrative medicine. We closely observed a creative work. And it could be a painting, it could be a poem, it could be a dance, it could be a song, and the list goes on and on. And we also, in a typical signature narrative medicine workshop, I would give you a prompt that is related to some idea contained in this work of art, but I would ask you in a very time-bound way to write about something in the direction of your own life. So I might ask you a prompt, I'll give you 5 minutes, and I might say, write about a time when you were moved by witnessing another's journey. Or I might say, write about a time when you didn't have all the answers. Or write about a time when you were deeply concerned about the welfare of another. And there's many different prompts we could write about. But the idea is it connects to the painting and it asks you to tell a story about your own life. You write that, and typically in our narrative medicine fashion, the next stage is we would be together and we would actually read what we've written to one another. And you can imagine this generates some anxiety for people. Gosh, I have to write and I have to share. But that's our signature methodology. And we focus on stories of patients and self and others the foundations of this field, which were born around the year 2000 at Columbia University. And now it's global. You know, you'll meet Pam Schaff soon, who runs a narrative medicine master's program at USC in California. It's really built on many different fields: literary studies, narrative theory, phenomenology. Why do we do this? Why are we doing this in healthcare? We're trying to develop certain capacities. Number one, by observing a painting closely, reading a poem closely, watching a film closely, and engaging with the formal elements, and that's key, engaging with the formal elements of those media, we're training skills of attention. With the visual arts, training visual attention, observing details, observing your own perception, and recognizing that that's going to be different than what someone else sees, right? Same thing with a poem. What are the words that are used? What is being said? What isn't being said? What's the mood of the piece? What is my emotional response? We want you to develop attention to the self as well. And our patients and their families and our communities need that capacity for attention when you're with them and caring for them. We're also writing. And we're not saying that you're putting down on the page what you already know. We're using writing as a form of discovery. It is time-bound. There's no time to plan. And oftentimes the prompts are ambiguous, connected to metaphor and story. And we say, go where the pen will take you. And oftentimes when the writing occurs, people write things they were not even anticipating that they would write about. They discovered things about themselves and others in the process of writing. Phenomenologists say that we live and experience our world in kind of fragments of memory, association, experience, and we as storytellers tell stories to others, and here we're writing stories and telling as a way of taking the events in our lives, giving it sequence, giving it shape and form, and in doing so, imbuing our lives with meaning. That's what we're doing when we're asking people to write. We're asking them to narrate as a way of making meaning. And we can see how this would be very important in training environments where people are engaged with very difficult, challenging situations of sickness and health and illness. They need opportunities to pause, reflect, and make sense of those experiences. By doing this in a group, we learn things about each other. We learn to trust one another. We take risks with one another. In medical teams and healthcare teams and teams of all kinds, you can see how this might enhance relationships. And throughout it all, we're engaging with modalities of creativity. We're asking people to create, and we're explicitly saying creativity is not just for the professional writers and artists and musicians, but creativity is a concept that is core to every human being. It is a capacity that we have as human beings that's allowed us to survive. And it's a capacity that allows us to innovate and make the world better. We have to come to our jobs in healthcare with that spirit of creativity so that we can make healthcare better and care for our patients better. And we've seen these outcomes in several studies. In one study where we took medical students from Columbia and Cornell to the Metropolitan Museum in New York City, this is a 4-year evaluation, mixed methods, we showed that instruments that measure reflective ability improved. The qualitative outcomes showed that the participants slowed down their observation, grappled with recognizing that there's uncertainty in what they're observing, also recognizing that multiple points of view are actually beneficial in understanding something as a group. And also they noticed doing this kind of work provided a kind of sanctuary where they could restore. You can see how all of these things have valence for healthcare teams. We also implemented narrative medicine methodologies, like I've described, like a little bit like you've tasted, in practicing healthcare teams. This image is a family medicine clinic in New York where we met with them on a weekly, actually on a monthly basis for a year. There's social workers, resident physicians, medical students, medical director, the clerk that checks patients in at the front. everyone is in one room together and they're doing the same work that you did, looking at a poem, looking at art, writing and sharing. And the outcomes that we showed is that there's statistically significant improvement in a metric that describes team function. Things like trust, communication, right? Relationships, those were enhanced. The qualitative outcomes showed that there was restoration, just like the students mentioned, that also communication, particularly across hierarchy and across profession, was enhanced. The clerk that checks patients in at the front said, I never knew that about my medical director. I never sat in the same room and had a conversation about their family. This type of work allows this type of connection. And another participant said, we all were working together a little bit better outside of that room and actually while doing clinical care. So I want to thank you all for this little exercise together and just to touch about the kinds of outcomes that we might see that are pertinent to healthcare. Now I'm going to pass it back on to Professor Vish. Thank you.
Thank you, Dr. Gowda, for this very absorbing exercise that encouraged the participation. I'm sure there are a lot of comments and questions on what you just said and what we just went through. Before we do that, so let's go to the other wonderful panelists we have. We will next hear from, I'll just introduce both of them, and then we'll hear from them sequentially, and then come back to Dr. Gowda. The next panelist is Dr. Pamela Schaff. She's a professor of clinical medical education and family medicine and pediatrics at the Keck School of Medicine at the University of Southern California. She directs the Humanities, Ethics, Art, and Law, HEAL, program at the Master of Science in Narrative Medicine program there. She continues her clinical pediatric practice in family medicine and has held roles such as Director of the Introduction to Clinical Medicine program and Associate Dean for Curriculum. With a PhD in Literature and Creative Writing from USC, her work integrates arts and humanities into medical education. Her research focuses on professional identity formation and narrative medicine. And she will be followed by Dr. Nidhi Lal, who is a faculty member at Boston University, Chobanian and Avedisian School of Medicine. She has won numerous recognitions for her work, including from one of the Massachusetts counties as a Community Clinician of the Year, which honored her for her professionalism and contributions to the medicine. Dr. Lal's career highlights include extensive work with underserved populations, mentoring medical students and residents, and advocacy at the local and state levels. She's dedicated to training general practitioners in India to enhance global health and improve maternal and child health outcomes in the tribal communities. So we will hear from both of them, followed by Dr. Gowda, and then we'll open it up. So Pam, you want to go ahead?
Sure. Thank you so much for that introduction. And Deepu, thank you for that beautiful exercise that is such a lovely introduction to the work of narrative medicine. I wanted to just share a little bit about how we have integrated narrative medicine at the Keck School of Medicine of USC. At USC, the humanities are integrated, and narrative medicine in particular, throughout all 4 years. And I'm going to spend just a little bit of time talking about 2 interventions that I think will give you a sense of what this looks like in a medical school setting, what it looks like in a course, and how it is affecting the way in which we're training our students. So narrative medicine is introduced in the year 1-2 professionalism course with the session on narrative humility. And students then apply this first lesson to their very first encounter with a patient in Introduction to Clinical Medicine. I'll talk a little bit more about that as one of my examples. There's narrative medicine content in the health justice course at USC, as well as the transition to clinical practice, which serves as an introduction to the clinical year. In a few minutes, I'll talk about the narrative medicine workshop that focuses on professional identity formation in the family medicine clerkship, so you can see what this looks like. And this year, as part of our new curriculum, we're in the midst of a curriculum renewal. Our students were required to take a 2-week senior seminar, and they could choose from several options. And so we had, for the first time, a senior seminar in narrative medicine focused on workshop pedagogy and on applications of creative writing. And to our surprise, over half of the students in this seminar decided to pursue optional scholarly projects in the field. So we're excited to see the way in which students are embracing this pedagogy. And finally, narrative medicine workshops are offered by faculty and those senior seminar students in partnership on topics related to residency preparation when they are post-match and getting ready to begin their training. The topics include things about uncertainty, about transitions in life and work, mitigation of burnout, and other topics as designed by the students and faculty. So very early in year one, our students are introduced to the concept of narrative humility. Our colleague from Columbia, Sayantani Dasgupta, says this about narrative humility. Narrative humility means understanding that stories are relationships we can approach and engage with, while simultaneously remaining open to their ambiguity and contradiction, and while engaging in constant self-evaluation and self-critique about issues such as our own role in the story as listeners, our expectations of the story, our responsibilities to the story, and our ownership of the story. So after an introduction to this concept, we ask students to participate in a telling and listening activity with their peers and to reflect on what they discovered. We ask them, what are some of the challenges and expectations and barriers? What did it feel like to have your story reflected back to you? Telling your story can be intimidating. Where do you begin? What do you include? What do you leave out? Listening also can be challenging. Do you fill in the gaps? We ask them to think about how this applies to patient encounters. And the following day, when they see their first patient in the Introduction to Clinical Medicine course, they apply what they've learned to this encounter. We ask them to reflect in writing on several questions after they see their patients. And in this way, we help them integrate these lessons. We ask about the ways in which the story surprised them or contradicted their expectations. We ask what questions they asked the patients that they hadn't intended to ask and what prompted that. And we ask them to think about how they contributed to what Dr. Dasgupta refers to as a co-created story between themselves and their patients. So I'd like to share what happens during the clinical year. This is a 75-minute session that takes place via Zoom during the first week of the family medicine clerkship before students go to their sites in the community. And these are the objectives. We ask students to read a story. Actually, they read or listen to 2 stories by physician authors and reflect on contemporary experiences in medical education and training. We discuss the importance of perspective, reflection, and self-examination as clinical skills that are critical to fostering narrative humility, empathy, and effective practice. And then they have a final assignment that is built on this workshop where we ask them to identify elements of their own professional values, integration, how they're becoming the physicians they want to be. And this is a final narrative assignment. So we have a pre-session assignment for them. We ask them to read 2 stories or to read one and listen to another. Laundry is a stream of consciousness narration that conveys the narrator's struggle as she reflects on her personal and professional identities as a pregnant woman, caring for a dying patient, clashing with her male colleagues, and managing her household. The podcast, which is an episode from The Nocturnists, tells a story. Surisha Narayana, a hospital medicine physician, discusses her strong identity as a physician and how it collided with her other identities as an Indian, a woman, and a daughter until one of her interns made a simple observation in the hospital. So our students listen to these, listen and read, and then they complete an assignment, which is to come up with some discussion questions based on the readings, and they bring those to the session. So we begin with an opening exercise, and we ask as students are arriving to imagine a picture of a typical doctor in their minds, and then to put a word or a phrase in the chat function of the Zoom session. And then we provide, and we after some introductions, we talk about what they've noted. And then we provide some background information on professional identity formation and narrative medicine. We ask students to get into breakout groups in Zoom and to share the themes that emerged from their discussion questions and to talk with each other. And when they report out, we ask them to talk about the ways they see professional formation and consider various elements of who they're becoming. Then, next slide, please. We do a narrative medicine workshop. So much like with what we experienced this morning, this is the image we show to the students. This is a webcomic by Dr. Shirley Bobby, who's a cardiologist just finishing her fellowship in Chicago. She began drawing comics as a way to process her feelings and experiences as a third-year medical student. We take 1 to 2 minutes to look closely, as we did earlier today. And the things students notice here, we ask them, what stands out? How did you see the image? What did you notice initially? What did you notice on closer looking? What emotions are evoked? And students are noted when they look and discuss, they note the position of the characters, the literal barrier you can see between the home and the partner and the physician's departure, what she's wearing, each of their facial expressions, the fact that he speaks in full sentences and she speaks in fragments of sentences. And after a discussion, we then ask students how this relates to the stories that they experienced in preparation for the session, how it relates to who they see themselves as becoming as doctors. And we talk about how these are all different. There are all different ways of expressing and realizing how our personal values inform our professional identity. After about 10 to 15 minutes of questions, we ask them to write to a prompt. And in this case, we have them write, as we often say, in the shadow of this text. So you can see one of the things she says is no, can do, got called in. We ask students to write or draw what it means to be called in. And as Deepu said, we give them only about 4 minutes. So they write to discover, and they share what they've written with each other in their breakout rooms and then report out. And we ask them, any volunteers who want to read may share. And we talk about the similarities, the differences, and what students have written about and experienced. So this exercise sets students up for the final narrative assignment when we ask them to tell us a story about their own professional formation. Yesterday was the wrap-up session for this current rotation, and the responses are so rich. The students write about seeing themselves in their patients, seeing our patients in ourselves, bearing witness, patient-centered care, the role of mentoring in professional formation. They write about trust and uncertainty and perspective taking, to name just a few. So I hope this has given you a sense of what narrative medicine looks like and how it can enhance instruction in early clinical skills and in professional formation. So with that, I'll turn it over to the next panelist.
Thank you so much, Pam. Nidhi?
Thank you. Hello, everyone. Thank you, Vish, for the introduction, Deepu, for your really thoughtful exercise, and Pam for really showing us how do we integrate narrative medicine into training the next generation. And this has been done very thoughtfully, very carefully. I am going to share with a few aspects of my journey, which let me start with, how do we tell our stories? This appears simple. We talk about our experiences all the time, but in narrative medicine, there really is a reflective arc, which we need to practice. And that's part of that curriculum that we would teach in medical education, in our residents, in our trainees. This reflective arc needs practice. It has many components, which is really known as a reflective cycle. And it includes the description of really what happened, the incident that we wanted to talk about, and teasing out one learning lesson. So we talk about what our feelings were during that event that happened, what was good and what was bad. How do you make sense of the situation, and what else could we have done? And then if that happens, what would you do next time? So that is one thing that is really important as part of a good narrative arc. Next slide, please. Another storytelling method that we really like to talk about in my narrative medicine teaching course is the work based on the work of Marshall Grants, which is really telling your public story, which includes the story of the self, the story of us as a team, and the story of now. The story of self is that of your own self as a doctor, as a healthcare provider, as a participant, which is based on a series of points which impacted the event and moved you to the place where you are at now. It really talks about the challenges that you had to face, the choices that we made to deal with the challenges, and the outcomes. And then the story of us is what is the story of the community, of the medical practice, of the school, of the college, and how do we learn, or how do we take these shared experiences with the choices and the challenges that we had to make and face, and what did we learn from that, and what was the learning lesson that we teach to the adults we train, and what is it there for them to learn from. The story of now is what are we going to do today based on these learned lessons and the strategies, an agenda, a plan, and how do we achieve the goals? So let me give you an example of the sharing of stories and the intersection with clinical education, clinical practice. I like to use an example of a story that I heard from my teacher when I was in my OB rotation in rural Maharashtra in India. As an intern, we conducted many deliveries with really in a basic setting with few resources. Postpartum hemorrhage was dreaded because mortality was really high. My teacher told me of a case when after the birth of the baby, as the placenta was being delivered, a bluish organ was also being seen. She said she immediately put on a clean, sterile glove, delivered the placenta, and returned the bluish flaccid organ made a fist and returned it back into the uterus or the pelvis, and felt it contract around her fist once the IV medications were started, removed the fist, and put the patient in a Trendelenburg position. That blue organ was the uterus. She saved the patient's life. Now, the learned lesson for me was act immediately. It saved lives. And I will never let a uterine inversion happen again on my watch. So this was a very quick, very simple example of a story as a clinical example and how we integrate it into practice and use it going forward for our trainees. So why do we practice or learn narrative medicine? We've talked about, presence, attention. We've talked about narrative humility. And as healthcare workers and educators, we know that empathy and compassion are key. People think that feeling sorry, the tip of the iceberg is feeling sorry for someone, but that's not really it. It's really what lays behind the surface. It's sensing those emotions, respecting patients' feelings without trying to change them, imagining yourself in similar situations, listening really attentively, listening to what's behind the lines, paying, as Deepu showed in the picture, paying attention to body language is really important. We really need to show this to our colleagues, our team members, our patients, and narrative medicine helps build those skills. There have been studies where the impact of narrative medicine program on healthcare providers' empathy was studied, and it was seen that the empathy scores improved post-narrative medicine program and was sustained 1.5 years later also. So innovation, application in medical education, we've seen that in my experience, narrative medicine-based medical education definitely helps improve health equity. It improves awareness because it talks about experiences of not only the patients, but even providers from marginalized communities and who've not been really allowed to tell their stories. And the way we practice this is in my department is through a MedMoth event, and I'll talk a little bit more about that, as well as some academic research projects where we use stories, we use art, and then we also use dance as a tool in medical education. And let me describe those for you. So the MedMoth. So the MedMoth is based off the Moth event, which is a nonprofit storytelling organization that hosts open mic storytelling events across the United States. We put a narrative medicine spin to this by allowing providers to share perspectives from their patient interaction. So the Department of Family Medicine at BU hosts a biannual MedMoth event. Since 2021, this was a COVID product, which went from fully virtual to a hybrid to now an in-person event. The participants are residents, medical students, clinical faculty. Each event is 60 minutes long. The MedMoth starts with an introduction of narrative medicine and a review of the reflective cycle that we talked about earlier. There are 4 to 6 speakers at each event. Each speaker is given or asked to give a story for 5 minutes. And some of the themes have been motivation, COVID-19 experience, advocacy, global is local. Participants have shared oral prose pieces, poetry, personal photographs. The outcome we've seen has shown that the MedMoth certainly improves the sense of connectiveness in the department. It fosters empathy. We talk about our mistakes too. It's not always good outcomes. We share mistakes so that others don't learn from our experiences. We plan to focus additional data gathering efforts that will teach us about long-term outcomes. We don't know yet, but we do feel that it has decreased burnout in our experience. My next example would be to use dance as a form of storytelling. We really used and learned from the public health events, the plays that have been done in India to share, to spread the message for public health awareness. We've seen HIV awareness spread through that, safe sex education spread through that. So we tried to use dance, and we used Indian classical dance just because we had 3 medical students who've been trained in that. We chose Bharatnatyam and Kuchipudi due to their expressive nature and the historical form of storytelling through that. And we picked postpartum depression. We picked postpartum depression specifically because of the stigma attached to this postpartum depression. You know, the birth of a baby is supposed to be a very happy event. We all focus on the baby, we all focus on good outcomes, and we tend to lose and not focus as much on the mother. And that's why we picked postpartum depression. We really found that we created a dance film that worked on the story of a mom having a baby and experiencing postpartum depression. We showed this to medical students, and we really saw that this allowed for a conversation. It opened up a discussion. Medical students were able to identify signs and symptoms of postpartum depression. We brought the mother back into the center of the conversation, and we talked about some things that mothers tend to not want to talk about as patients because they feel that they are not allowed to talk, and we gave them the space. The providers got paid more attention. And we really learned that through narrative learning through dance, humanized that stigmatized part of postpartum phase that mothers were dealing with. We encouraged necessary dialogue with a unique focus on the the stigma attached around postpartum depression. We also realized when we talked about this in grand rounds and in through multiple focus groups, we realized that here we had keep the postpartum appointment really 8 weeks after the birth of the child, because we want to spend time giving attention to the baby. Really, postpartum blues start much earlier, and this would be a good way to change a little bit of clinical care with the storytelling, with the education that we found. So I think this we demonstrated that this movie really allowed us to understand cultural context, allowed to find barriers in healthcare, and this really hopefully will impact postpartum depression narrative. What are we doing in my institution or through my work at BU to highlight narrative medicine? We've introduced narrative medicine in the LEADS program, which really starts at the first year for medical students, and we allow them to pick a topic which really would include either advocacy or narratives or health equity, and we allow them to build on this. They can, pick courses such as the doctoring course or the healer's art course through their education, which will again allow them to develop the narrative medicine skills. We have departmental projects, like I said, in the My Family Medicine, we have the Med Moth, where residents will share their stories. We've developed a podcast. We also have a faculty developmental program where we get a complete comprehensive narrative writing program that faculty can participate in. So we have incorporated this with medical education and faculty development and developed scholarly projects through this. And with this, I will turn it back to Deepu.
Thank you so much. Just wanted to pause for a second and just take in all that we've learned. We've just talked about 2 medical schools, and you see how many different ways there are to integrate the humanities, creativity, stories into the curriculum, and how it can impact learners in health sciences across the trajectory. Whether you're talking about a first-year medical student or someone who's a resident, who's already a physician and now practicing and having responsibilities for supervised practice. And as I shared earlier, this also can impact practicing clinician, practicing teams. And there's so many ways that we can apply this. So what we're doing now is just saying, here are the different ways we've done it. Maybe this will give you some ideas on how you might wish to train further and how you might wish to implement this in your own settings, whether you're a professor in literary studies or English, or whether you're a physician, or whether you're entrusted with training nurses, many different applications. So I know it might feel like a lot, but just take it in and take what is useful to you. And after I present this, we'll have a chance to hear from you also in terms of questions. What I'm going to share with you now is how we've implemented narrative medicine methodologies in Kaiser Permanente School of Medicine. As Dr. Vish mentioned to you, I was at Columbia University. I was there for 20 years. I trained in internal medicine there. I joined there in 1999 when the field of narrative medicine was first getting started. And I just happened to be in the right place at the right time. My very first month of internship was working with Rita Sharon, the founder of the field. And we read together, we wrote together. And I've been connected with her and that team ever since. The reason I left Columbia in 2019 and came to California, where Kaiser Permanente School of Medicine exists, is because Kaiser Permanente is a brand new medical school. We started in the pandemic in 2020. Just a month ago, we graduated our very first class of students. So now they're out, out in the world and getting ready to start residency training. And the opportunity to create a new school, and I think importantly, a new culture that is centered around narrative, centered around person-centered care, was an opportunity that was too great to pass up. And it was a big leap, but it's been an extraordinary journey. And I mentioned this idea about starting something new and creating a new culture, not because it is singular to our school, but rather to challenge you to think about that concept as something that can be generalizable. Whatever institution you're at, whether it's 5 years old or 150 years old, how can you revitalize knowing that the project is never finished? Even though the building there on the slide, that's our building at the medical school, is completed, the project is never finished. And I think we can say the same thing about healthcare, whether, in South Asia or globally, the project is not finished. And so how can we continue to revitalize and see the possibilities of making it better? And what we're talking about is making it better through narrative and creative works. We've been fortunate in being able to start from the ground up. We've implemented narrative medicine from day one. The very first evening of the first day of medical school during orientation is our students are asked to look at the same painting that you just spent time looking at. They look at that painting on their own, and they're asked to take the perspective of one of the figures in the painting or an object in the painting and write from the perspective of that figure or object. And you would be amazed at how empathic, creative, nuanced, enlightening those comments are. And what it tells me is that on day one, the students come in with those capacities. We don't have to teach them to care. We don't have to teach them to be empathic. They come into medical school having those capacities. Our job is to not diminish that, to not let medical training diminish those inherent capacities that come in with. And that's what the literature shows. The literature shows that the process of medical training actually, those capacities deteriorate. So our job is to maintain it and to enhance it. But we start with it on day one, and we also communicate to students, this is important. Engaging with creative works, writing about what you observe and sharing with one another is a core element of your medical training. That's what's being conveyed implicitly by starting on day one. And we continue our narrative medicine curriculum across the entire 4 years of our curriculum up until the very end. So that's one thing that we're fortunate to do. If you're thinking about applying this at your own institution, that's something I encourage you to think about too. How can this approach not be siloed? Meaning it's not just a 6-week elective, or it happens during first year and you never come back to it. But rather, how can you partner with different course directors across the trajectory of your curriculum and think about implementing these methodologies across the arc of training? Then it becomes something that's not out there, but something that we do together, and it's an inherent part of your identity as a physician. So why are we doing this? One is we're developing skills of empathy. We're talking about what learning objectives can be met through this methodology. We know, we've talked about already, and Dr. Nidhi described it so nicely, empathy, the skills we need to connect with another, looking at a painting, imagining what someone's experiencing, reading a poem, imagining what they might be thinking, being aware of your own emotions. Those are development of skills of empathy, something that we absolutely need for healthcare. We're also advancing learning objectives related to clinical skills. So if you are training yourself to carefully visually observe, to notice the details, to see where your interpretations come from, to notice when you might be missing something, those are the same skills that you need when you go to a patient and you look at a finding on someone's skin, is to slow down your observation, to observe, to describe, and then to interpret. You see how they're different? If you just jump to an interpretation without slowly observing and describing, you might be jumping to the wrong conclusion. So you have to unpack, what does your interpretation come from? And we oftentimes don't slow down our looking to look for the details. Many of us missed the woman in the background, the mother in the painting. So slow down, look around. What do you notice? Development of a clinical skill. Also listening. We have in our narrative medicine methodologies, telling and listening activities where we carefully listen to the story of another and saying, this is a discrete clinical skill that you need at the bedside. We also use this work to explore diversity, equity, and inclusion. So what we mean is when you are choosing a text, could you choose a painting? Could you choose a poem that speaks from the perspective of someone in society whose voice might be diminished? And in America, we think about persons of color. That's the term that we use. Black Americans, Asian Americans, Latinx Americans, people who are indigenous to this country, indigenous persons of America. Oftentimes, these are voices that are silenced. There are voices that often are not heard in settings where decisions need to be made. So could you, in the choice of your text, choose those voices? Could you have your students read those voices and try to grapple with their perspective and how they're experiencing health and illness? Right? Could you use text to surface biases that might come up in the viewer and have that as a point of observation? There's many different ways that we can promote that through our narrative work. We also look at how stories function at the societal level. We often think about stories as dyadic, the physician and the patient. Racism is a narrative. Sexism is a narrative. Ageism is a narrative. These are stories that function at the societal level, that configure the way we organize ourselves, and can actually perpetuate harm. So we have a 4-part series in year 2 of the medical school where we start with stock narratives. What are those stories that are ubiquitous, that might maintain the status quo and might perpetuate injustice? Then we talk about concealed narratives in session 2, whose voices are not being heard. And then we talk about resistance narratives. What are stories of people pushing back and trying to make social change? The last session, we talk about speculative futures. And we use speculative fiction to actually explore this. A writer named Octavia Butler, who's native to this area, where we explore their own imagination. How can students imagine a different future that doesn't yet exist? We also use this for professional identity formation, meaning using reflective writing across the arc of training so the students can take a pause, can write and share, and talk about the experiences that they're having and how they are becoming physicians. We're not born as physicians. We are integrated into this profession slowly. And so to have a reflective process in that change over time is absolutely essential in helping them make that transition in a healthy and safe way. And we're also thinking about how stories can be used for social advocacy. We have a session on how stories function, the structure of stories, and have them develop stories as a way of conveying a message to sway opinion and to advocate for someone, a patient, a community. And we have them use stories to be able to convey an argument. We also, the very last assignment that we have in our 4th year in the narrative medicine and diversity curriculum is around writing op-ed pieces, writing opinion pieces for a newspaper, a journal, or a magazine, you've learned these skills of writing and conveying stories. Now write in the direction of the public space to be able to sway public opinion in the direction of health equity. I'm going to share with you this last slide and I'll conclude. This is a session that we had just this week. This is at the end of our 1st year. We take students for half a day in this important land in the central space in Los Angeles, near Chinatown, Los Angeles State Historic Park. We take students out of the classroom into this sacred land. This is where the Los Angeles River used to run through. This was a settlement of the native people of Los Angeles Basin, the Tongva people. And we say, let's learn about the story of the land, story of our communities. And what we do in this half a day, as you can see in the bottom right picture there's a woman speaking. That is an elder from the Tongva community, Elder Calderon. She talks to the students. She does a land invocation saying, this is sacred Tongva land that we're occupying right now. She talks about how the Tongva community still exists and how we can learn about native knowledge to take care of our patients. And one of the native knowledges she talks about, it is our responsibility to care for the land for the next 7 generations. So that's a story. It's a story that is often not heard, but it's a story, if you take in, can really transform the way you think about our relationship to climate and the environment that we absolutely know has deep health implications. And as a part of this session, the students observe and discuss 4 large works of art that are on LA State Historic Park. And the top right image is one of those sculptures, right? So this is another example of taking students out of the classroom, engaging with communities, listening to different stories, and doing the work of interpretation. And I'll end actually by asking us to think about healthcare as something we have a relationship to. Healthcare is something that we are wanting to make better. And actually we'll go back to Professor Barnashri's comment. And she says, the painting implies that the doctor is still wondering on the process of her recovery. And I'm going to ask you to think about healthcare as the her. We, as healthcare professionals, are still wondering on the process of healthcare's recovery. And there is still hope for the recovery of healthcare. Thank you all so much. And I'm going to pass it over to Dr. Vish.
Great. Thank you, Deepu. Thanks for, and also my thanks to every panelist. Maybe we can take the slide down so that we can see each other. So before we start with Q&A, let me, so for those who have questions, please put them in the question and answer box. We will get to them right away. We just have about 10 minutes exactly. So I have a lot of questions for the panelists, but in the interest of getting to the questions posed by the audience, let's go to the question that has come up on, is there scope for digital health solutions? We are in the so-called digital era. How do you see the narrative medicine playing out in the age of this digital era? So who wants to take it on? So maybe all 3 of you. So, Nidhi, do you want to start off?
Yeah, I can attempt to do this. I think, and I'm thinking with the digital health, you're meaning that how do you convey your stories through digital media? And part of that would be, podcasts and I don't think sharing that experiences is any different, whether it is in person or via digital medium, I would encourage that. Personally, I do think there is a human touch to everything, and I would definitely value keeping that if possible. I really don't think I have any more to add to that.
Let me
Deepu or
be
Pam?
more specific on that. Let me be more specific on that, so that because we do have a lot of movement towards telehealth, right? You know, so which is great because it's providing access to geographies, communities that are otherwise difficult to serve, quote unquote, difficult to serve, you know. But the human touch, you all kept saying the human touch. So what does it mean to have that human touch when I'm not just talking about the, you know, the touch itself, you know, what does it mean to be human when we are practicing so-called telehealth or through other kinds of digital technologies, which is asynchronous sometimes, you know. So that's where I think, you know, the question is coming from. So Pam, you want to take a shot at it, and then we'll go to Deepu? No, so.
Sure. I mean, one of the first things that occurred to me was some of the challenges are also, on the flip side, a gift in a way. I mean, I've found at times as a pediatrician, a telehealth visit allows me to have a window into the home situation of a family relationships, who's there, how chaotic is the home, how much do I see, you know, what's the connection between the people in the room, in their own home, how's the child playing, and those things we don't get to see in the clinic space. And so I feel like there's an opportunity for even more sense of story and more, you know, and it's a great opportunity for teaching students, frankly, you know, for them to be able to see that in a way they aren't able to see it in the clinic.
Mm-hmm. Mm-hmm.
Pam, that's a wonderful answer, and I would agree with that wholeheartedly. You know, this is definitely a reality of our world now, and I think we have to think about a couple things. One is what is being gained by telehealth, but I also think we need to be very aware of what are the trade-offs as well. And you mentioned touch. You know, we often think about physical touch in clinical settings as a form of information gathering for diagnostic purposes, and that's true. But at the same time, touch has other implications as well. Touch is not a unidirectional flow of information. It's not just I'm learning about the patient through touch, but touch is a form of communication. There's something that happens when we listen to the heart and place the stethoscope on the chest, when we place a hand on the patient's hand. Attention and connection is happening through a sense of touch that is different than what happens when we're communicating here by the screen. And that's a trade-off. As you mentioned, Dr. Vish, you have access when you have virtual care, but you lose the opportunity for physical touch. That is a unique and distinct aspect of human connection. And so when you are able to see the person in real space, utilize that power of touch as a form of communication and connection with the patient. Let's not just, you know, forget that amazing resource that we have. And I think about the work of Clayton Christensen, who's passed away, who was at the business school, at Harvard Business School. You know, his concept of disruptive innovation said, you know, you have industries that are stable, and then usually a technology comes around that makes the delivery of that service either more efficient, more easily accessible, cheaper, where the quality is, quote, good enough. And this disrupted computers, it disrupted steel industry, it disrupted automobile industry. And the question is, will virtual care and artificial intelligence ultimately disrupt healthcare? It's up to us to kind of ask the question of, what does it mean to have quality that's good enough? And I think that's what concerns me a lot about technology, is there's going to be a lot of benefits, but what about the core aspect of care and connection and supporting patients through tough times through the things that we're talking about today, let's just stay vigil to make sure that's not lost. And that remains core of what we mean by quality healthcare.
Right. Thank you. That's wonderful. I
Can
hope
I
I
say
have
one
done,
more point?
yeah,
Sorry.
quickly. Sure.
Yeah, thank you for clarifying. I missed the telehealth part, but so I just want to add to Pam and Deepu's comment. So if you talk about the role of narrative medicine in digital health, maybe I would envision this as a sharing of our experiences with digital health and seeing what are the lessons we learned. What did we learn and what did we miss in that field of vision that we got to see on telehealth? That's all.
Yeah, no, great point. In fact, I was about to say that question, I hope I have done partial justice, at least to that question that Dr. Umar raised, because there are a lot of aspects to that. And I think I zeroed in for the sake of generating an answer to digital or the telehealth. But there are, the whole idea of asynchronicity, you kept using the term dialogue, right? I mean, what does it mean when we are asynchronously responding? I think the convenience, I think it goes back to Deepu's point, and the convenience of providing care at a time and place, we are gaining something with that, but we may be losing something too, or at least be cognizant of what we may be losing. So I have one more question. We have only 3 minutes, so maybe all three of you can jump in. And and the question in the Q&A box, and as well as in my own notes here. So what kept coming back to me, and this is not a cynical question, by the way. This is I encourage everybody to be skeptical, not cynical, right? So one thing that kept back to me, the individual versus the system. The individual is a practitioner. What you are trying to do, humility, trust, empathy, dialogue as outcomes. But there are physicians who are burned out who say the system just is not set up for this kind of reflection. I have 10 minutes to 30 minutes or 40 minutes, whatever it is, to see the patient. The systems I am in certain conditions, certain areas, do not allow me to be reflective, do not allow me to practice this, for whatever the clinical conditions are. How do you respond to that? Because this is so fundamentally important that we are trying to humanize everything here, which is what the profession is about. Whereas the system can grind you down, So maybe quickly with each of you responding, we just have about a minute, so quickly. So shall we start with you, Pam, and then go to Nidhi and then Deepu, and then we end it there. So.
Sure, it's a wonderful question. I have 3 answers. I'll try to be quick. One is this method, actually, the kind of close attention and listening, I firmly believe that it actually saves us time. If we make the space for a patient to tell their story and don't interrupt them and just listen, a huge wealth of information is gained that's so important to our care. Second of all, the stories we tell to our health systems are really important. And if we're good storytellers, I know I've been able to advocate for change in my health system. If the templates are crazy and there's not enough time for me to see an adolescent patient and I feel it's doing harm to my patients, I am not afraid to speak up and try to advocate for those changes. And I forgot the third point, so I'll defer to someone else.
No, thank you. Nidhi. Yes.
I agree with Pam. Burnout, but I'll say burnout is real. And I will say, we keep going back to the question, we chose medicine. Why did we choose it? So to Deepu's point, when we walk into medical school, we all have those skills of empathy, compassion, humility, and we need to maintain and foster those skills. The other part I want to jump into is when we don't only just listen to our patients, we also listen to our colleagues. We see their body language, we see who's burnt out. And when we talk about our mistakes, when we talk about our negative feelings, and we have those sometimes, it's just been a horrible day. We talk about that, and then we say, oh, you had it too. Oh, maybe let's just take a break and take a breath together. Maybe get some oxygen in all our lungs. That helps. That feeling of community is definitely what helps us stay connected. And we only feel connected through these stories. Deepu, I'll pass it on to you.
Great. Thank you so much. I think we are over a minute, but Deepu, you have the last word. Quick one.
Thank you so much. If you think about the mission statement of narrative medicine at Columbia, it is, we listen to stories with openness, with our close listening, so that we can be moved to take action. That's the purpose of narrative medicine. And we listen to our patient stories so that we can be moved to take action on their behalf. Same thing applies to the system. We listen to the stories of people engaged in healthcare so that we can be moved to take action to make healthcare better. And I think that's our job. Healthcare needs fixing. It's not done. And the systems are not conducive to the kind of work that we want to do. And so we have to keep using stories to advocate for a more human-centered healthcare system.
Right. Thank you so much. We can spend another hour easily answering and responding to those wonderful questions from the audience, as well as the ton of questions I have here. But unfortunately, we are out of time. But let me thank you, Pam, Nidhi, Deepu, for the wonderful contributions and conversations. Hopefully, this is a starting point of a conversation. We'll continue to engage in this dialogue or multi-log as it is. But thanks for taking the time, particularly in the West Coast. It's very early in the morning. So thank you for doing what you have done and the immense amount of work you have put in to prepare for this. I also want to thank the audience who have been very patient, who tuned in from different parts of the world and asked these questions. Thanks for those insightful questions and participating in that exercise early on. And last, again, I would be remiss if I don't thank our teams from the Mittal Institute at Harvard, as well as the Harvard T.H. Chan IRC India Research Center. It's just awesome, amazing amount of work they have put in to make this possible in the background. So Monica, you and your team deserve a special thanks for the work you are doing. So let me thank everyone. Again, hopefully we will have an opportunity to continue this dialogue in other forums at other times. Thank you. Bye.
Thank you so much.
Thank you, everyone. Take
Bye-bye.
care.
Thank you, everyone.